Welcome and good afternoon. Thank you for joining us for this Office of Early Childhood webinar. We're joined today by the Department of Public Health to talk about the reinforced need for continued health and safety practices. We're glad you could join us today. The broadcast today will be in English, but there are subtitles available in 5 languages. You can access the subtitles by clicking on the CC button in the bottom right-hand corner of your screen. And then when you click on that button, you'll be able to select the appropriate language. We will be providing an interpreted version of this video early next week in Spanish. We thank you very much for joining us today, and we will have ample time for question and answers after our presentation. You may use the question and answer feature of Teams Live in order to be able to send us questions during the presentation today. And so with that introduction, we are joined now by Commissioner Beth Bai. Commissioner.
Thank you so much, Rachel, and many thanks to DPH for joining us today. And of course, most importantly, thank you to you for joining. You have been such an incredible support to children and families through this pandemic, and we know you've been doing it in uncertain times. The reason we're having this webinar now is because things are changing and evolving as the virus changes and evolves, and that's the whole point of a pandemic. We've been working collaboratively with DPH throughout this pandemic, COVID-19, and we want to make sure today that you're as up to date as possible with health and safety practices. We can't stress enough how important it is to maintain these health and safety practices, to maintain safety and health in your program, and to reduce the spread of COVID in our community. If you watch the news, you know we're not out of the woods yet. Even though there's been lots of vaccinations, there's still a lot of spread, and we need to do, everyone needs to do their part. So we have safety protocols, and our memos are now up to date with some of the latest information on our website, and we update these as we get new information. So with that, I'm an expert on early childhood education, but Dr. Lynn Sosa has been our go-to person. She's an epidemiologist with the Department of Public Health. And Lynn, you've just been so gracious about helping us on things like webinars like this today, but I know you've talked to hundreds of healthcare and childcare providers over the past year, whether it's a nurse from a program, or a local health calling you about a program, or a director calling you. I know I've called you at 8 o'clock at night, and you've called a director back. I think it was 8 o'clock on like a Friday night because they wanted to know if they could open on Monday. So thank you for that, and thanks for being here to help us help programs at this point in the virus. And I'm sure there are questions about how things have changed. So take it away.
Okay. Thank you, Commissioner, and definitely happy to help everybody. So I'm going to share my slides, at least try to. Am I all set?
You are.
Okay, great. I just want to make sure. Okay, so yes, thank you for that, Commissioner. And I also want to say that I have my colleague Lexi Edmondson with me today. So we wanted to just take the opportunity to review the mitigation measures, which I'm sure everybody is very familiar with, but also go over a little bit of the data that you've also been sharing with us, and how we've been using that data, especially in regards to outbreak investigations and what we've learned from those and what we can share with you all based on those experiences. So here I have listed all of the mitigation measures. So we have mask wearing, which is something that I know has been perhaps maybe a newer introduction to childcare settings, but one that I think has been very important, and it sounds like it's gone really, really well. And I certainly think that while all of these are important, mask wearing is among the most important when it can be used. Distancing, whether that's among staff and cohorting, those really go together. And trying to ensure distancing among staff and attendees when that's possible. Again, recognizing that in childcare settings that might not always be possible. So then cohorting becomes really important, so that when somebody who is sick or is determined to be positive is identified in the setting, we're limiting the potential exposure and quarantine of the people in that setting. Cleaning and disinfection remain really important. We've learned a lot in the last year, and it is kind of a little crazy to think that we have been doing this for over a year and kind of how far we've come in all of these respects, but certainly cleaning and disinfection is one of those. And we've certainly learned that a lot of what we were talking about last year, we don't need to do. So for example, I know there've been lots of questions about the need for deep cleaning and things like that. That's not something that is recommended. It's really about making sure that you're doing regular and routine cleaning, as well as disinfection in your settings, and that is certainly sufficient for this virus. Hand hygiene, really, really important in childcare settings, even when it's not during a pandemic, right? For all of the other potential infections that can be spread in this setting. And so for this virus, certainly not any different. But I've kind of added two, because I think two kind of mitigation measures here, which might not always be viewed as mitigation measures, but they really can be considered as such. So obviously isolation and quarantine protocols. So everyone, and I certainly appreciate that all of us have had to be flexible over the last year as we have learned more and more about the virus and gained more experience with it. And certainly our isolation and quarantine protocols have changed over time in the last year as well. So making sure that everybody is up to date about those and what they are and what is the right time periods for making sure that if someone tests positive, so that's and stays home, that's isolation or is sick, and then quarantine. So for the folks that have been close contacts, first understanding that definition of a close contact, and then the appropriate period for somebody that's a close contact staying home, that's quarantine. And certainly making sure that those protocols, among many others, are written down, right? And regularly reviewed and updated. That's really, really important for making sure that everybody kind of stays up to date with this while you're trying to stay up to date with everything else. And then finally, but certainly not least, is vaccine. So now we've certainly have the availability of vaccine over the last month or so, specifically for these settings, which is really, really exciting. And certainly that's really the key for us continuing to see improvement with where we are in the pandemic right now. So I just wanted to share a little bit of the data. So as you all are aware, you all are reporting to us every time you identify either an attendee or a staff person in a childcare setting with COVID-19. So I just wanted to share a little bit kind of how we use those data. And so we certainly appreciate everybody sending us that information, making those phone calls, sending us those emails. We have had this figure in our weekly report. And so we publish a report Monday through Friday. And Thursday is the day that is the more extended report and has the much more detailed analyses, as well as our 2-week case rates and things like that. So that's the report that these data are updated in every week. And so this is actually the figure for today's report. So you get kind of a sneak peek of it, since this doesn't usually get shared until about 4 o'clock. And so you can see really over the last couple of months, we've really kind of seen a steady amount of cases among childcare attendees and staff. And I would say that this is not unexpected, given that we still have a lot of virus around. We really, in January, saw the peak of the second wave. And while our case rates have come down, they have certainly plateaued over the last couple of weeks. So it's not surprising that we are continuing to see cases in this setting. But I wanted to make sure that people were aware of this figure and where they can find it. So in addition to just hearing about individual cases, outbreaks, clusters, so more, and our definition of an outbreak is more cases than you would expect to be seen. And so certainly we're not always concerned about one case in a childcare or really any other setting, but once you start seeing a group of them together happening around the same time, that's a situation that we would be concerned about and want to look more into. And so we have certainly been working with you all, with local health departments, in having these reported to us and trying to learn more about them. And as we have investigated outbreaks in childcare settings over the last many months, and I will say that we've been actively doing this probably since the late summer, we've definitely seen different themes that have come up again and again when we're looking at these outbreaks. And these, I think, are the top 3 themes that we've seen. I don't want anybody to think that these themes are unique to childcare settings, because they're not, but they're definitely ones that we have continued to see over the last 6 months or so. So it includes things like working while ill, and this is particularly for staff, social distancing, especially again among staff. So not necessarily staying, that 6 feet apart. And then issues regarding cohorting, and this can include those related to attendees or staff or both. So in that vein, we wanted to highlight 3 outbreaks that we have investigated. Again, these are representative of these themes that we continue to see, and just to try to highlight kind of the information and what we have learned when we've done these investigations. So we have 3 to share. Each one highlights one of these, but you can one of these themes. But at the same time, you'll see that there is often overlapping themes, which kind of makes sense in terms of understanding how these outbreaks might have occurred. And so I'm going to go over the first one, and then Lexi's going to go over the second too. Okay, so this is outbreak number 1. So in this outbreak, we had 7 staff members and 6 attendees who were affected, but that did result in many other people at this particular childcare facility needing to be quarantined. So about 80 other people. And there were reports of secondary transmission among the contacts. So meaning that of the people that were quarantined, whether it was from the childcare setting first or household members of the people that tested positive, many other people were affected. And so I think when we're looking at outbreaks, whether it's in childcare settings or other settings, it's really important to understand the impact, right, of even just a few cases that can have. Whether it's in that setting or even outside of that setting. And in this particular setting, so on the right-hand side here, you have the figure. This is what we call an epidemic curve. It allows us to kind of give us a snapshot of what happened. And so we have kind of the line at the bottom is kind of over time by day, and then the number of cases that were reported by day. And so in blue are the staff, the green are the students, and in gray we have the staff that were like floater staff, and I'll get to why that was important in a minute. But one of the first things that we learned about this outbreak is that staff members reported working while ill. And this is really tricky, and we're not trying to blame anybody here in any way, shape, or form. It's really about people really being in tune with their symptoms. And this is something that I think all of us are trying to get our head around. So before COVID, we all know that it was very common for people to go to work, go to school, if they had a cough, or if they were sneezing or had a cold, or even if they had like a flu, right? If they felt like they were well enough to still do what they had to do at work or do what they need to do at school, that was an accepted practice, right? We were all going around, even if we were a little bit sick. But I think what we've learned from COVID is that we really can't do that. And it's really, really important that people are very in tune with their symptoms. And if they have any symptoms, they really should be staying home. And even if those symptoms, someone gets a test, that's great. The test is negative. Even if the test is negative, if they're still symptomatic, they need to stay home until they're not symptomatic. And then I think that's really a culture change that we all are still getting our heads around. But these are the types of situations that we find out, when someone does work while they're ill, again, they don't know that they have COVID or they don't think that they do. These is kind of the things that we can see happen as a result. Okay, so in this situation, we were actually able to get a lot of information. And again, I just wanted to kind of share this particular situation, because when we have this level of information, it really helps us understand what we think could have happened in this situation. So this is a pretty large childcare facility, and so we have pictures here to kind of delineate the different people. So we have the staff, we have the students, and again, in this situation, there were floater staffs. And again, we know that this is a common situation for childcare settings. But once we were able to kind of map out the different classrooms that were affected in this situation, and you can see at the top here, we have each room, how many people were affected. as well as, so that's the number of people in the boxes, and then the total number at the top. So what we learned in this situation is that the person that happened to be working or while ill happened to also be a floater staff. And so that was a situation where not only do we have somebody that's sick who's working and exposing other people, but the fact that this person was floating to different rooms allowed more people to be exposed and then potentially infected. So that is kind of a combination of those two issues of someone working while sick, but also the lack of cohorting issue of the staff. And in addition, in this situation, we also learned that for rooms D and E, that while they were separate rooms, they actually were combined in the morning. And so that explained why there were some kids in a room where none of the staff got sick, but some of those students got sick. It seems likely that they were exposed to people when they were in that combined situation in the morning. So that was just one situation that highlighted those themes, and I'm going to move on to the next one and pass it over to Lexi.
Hi. So for our second outbreak to share, we have a similar situation with that cohorting concept. And so with this situation, we had 30 cases that arose within the facility. 9 were staff and 21 were attendees. And this affected 3 of the 5 total classrooms within the facility. And then beyond that, you see in purple on the chart here that there were 12 secondary cases that were identified. So those household members of staff and attendees that ended up becoming positive as well. And so I wanted to focus on 2 rooms. So I mentioned that 3 rooms were affected in total, but I wanted to focus on 2 rooms because they had the bulk of the cases. So I mentioned there was 30 cases total, but these 2 rooms accounted for 24 of those cases. So 6 cases were in a different room, but that room had no overlap with these 2 rooms. So rooms B and C, they actually share one of their teachers. And so this teacher had become symptomatic after actually receiving a vaccination. And so thought that she was feeling side effects from the vaccination, did not come to work. So that was really key here as well. Thankfully, this individual did not come to work while feeling these, what she thought were side effects, but ended up becoming symptoms, and then did get tested when those side effects did not subside, tested positive, and then both of those rooms that this individual had worked in were closed, and those individuals in the room were quarantined. But what was interesting as well about this situation is that every single staff member that was in these 2 rooms had subsequently tested positive, and 73% of the attendees within these 2 classrooms had also tested positive. So this was a hard hit 2 rooms. And that cohorting had, like Lynn had mentioned before, had potentially exposed more people than if each teacher had only been in 1 classroom. So for this one, another outbreak situation that we had seen, this one was interesting because this facility actually had 2 different wings with multiple classrooms on each side, and only 1 wing was affected. So there were 11 cases in this 1 wing, and they were almost all staff. It was 10 staff and 1 student. And so we grouped these cases into 3 different, there are 3 different rooms. So there was 3 rooms, but what was also interesting was that each of these physical rooms had 2 classrooms within, and they were kind of separated by a half wall, which I think is pretty common. And then in between these 2 rooms was also a shared kitchen, little kitchen space, and a shared bathroom changing area. And so we grouped them by physical room, but they were there were staff members from each side in some of these cases. So the first physical room had 7 cases. We did see in this situation a staff member who had worked while symptomatic, and these cases came from both sides of the room. The second classroom had 3 cases, again from, they were not all from the same class within the physical classroom, And then the last case that we saw was the only case in the third physical classroom in this wing. And on the next slide, we just have kind of a map of how these all played out. So for each color, we see the cases that arose in each physical room. So on the left-hand side, the darker orange represented one classroom within that physical room. The lighter orange represented the other classroom within that the other class within that physical classroom. And then same with the yellow. The light yellow on top was one class, and then the darker yellow was the other class. And we only saw that one student case, which has the asterisk over it on the left-hand side. And so with this one, it was interesting to us that it was mostly staff, and also that the staff on this wing of the daycare, which was a child care facility, which was different than the other wing, was that these shared spaces, the kitchen, the changing room in between each of those classes within the physical classroom, those were really small and didn't allow for, proper distancing if more than one individual was in those spaces at a time. So with this one, we saw kind of that working while ill, and also the distancing aspect of it, where it was hard to do that in a lot of cases.
Thanks, Lexi. So again, we are presented these three situations to be representative, which I think they are, of the many outbreaks that we have investigated in childcare settings. And so again, some of the lessons learned is that really any staff or attendee with symptoms should not be at a childcare facility. They also shouldn't be at school, they shouldn't be at work. And so this is the message that we're trying to give everybody at all levels. And I think what's especially important for childcare settings in particular is that one mitigation measure is limited. So understanding that not everybody that is in a childcare setting can wear masks, for example. The others become even more important. So making sure that we're doing everything we can to implement all of the mitigation measures, and understanding that in childcare settings that we're not always able to do that because of the nature of the setting, we have to make sure that all of the other measures are implemented 100% of the time. And clearly in that vein, cohorting is a really important mitigation strategy in childcare settings. Understanding that's not always possible, but trying to do it as much as is possible is going to help prevent these situations from happening in the future. And then making sure that there are written policies that are regularly reviewed and updated, understanding that staff can change and come and go, and attendees come and go. That's a really important part of this, to make sure that everybody understands what the mitigation measures are, how they're being implemented, and so that everyone can do that to the best of their ability. So I think that was really the end of our presentation, and we wanted to be able to share that and certainly have more than enough time for questions. So thank you.
Thank you, Dr. Sosa. This is Rachel Leventhal-Weiner, our Chief Research and Planning Officer. And so we do have some questions from our audience, and a number of the questions are for you and Lexi. So if maybe we could start with a couple of those questions. And Commissioner Bai, there are also some questions for the agency as well. So to begin, there are a number of questions around a plan for lifting mask restrictions for children 3 and up. And if you could give some insight into either that information or that plan.
So I think the question is basically whether the mask mandate will be lifted?
Correct.
Yeah.
Whether it's a rumor or not.
Yeah, I have not heard of any plans for that happening. My understanding is that the original mask mandate was put in place at least through the end of May. I think that was the last thing I heard, but I don't know if Commissioner Bai knows better about that, but there's certainly no plans that I'm aware of for a firm date for that.
Okay.
No, there are no plans, and there are no plans right now, and we'll be working with DPH and the Reopen Committee on that. But through almost the end of May, the executive order remains in place.
Okay, great. Thank you, Commissioner Bai. So there's a question about some of the routine cleaning and disinfecting you mentioned at the beginning of the presentation. Is it necessary to disinfect bathrooms between cohorts?
Okay, so I will readily admit when I am not the most expert on a particular topic, and cleaning and disinfection is not my exact topic. I think, so I'll just say a couple things. So CDC did recently update their guidance on cleaning and disinfection. However, when I talked to our SME, our subject matter expert on cleaning and disinfection, he tells me that basically that our guidance on this is basically what CDC's guidance on this, and it hasn't changed, and we were, I think, ahead of the curve on some of that. So I guess the question is that specific scenario addressed in the cleaning and disinfection guidance? And if it's not, I can certainly get back to you.
That's great. That's really helpful. The next question actually is about the difference between the DPH's and CDC's guidance. So does DPH advise keeping a 14-day quarantine rather than changing to a 10-day quarantine as the CDC advises?
Okay, so when CDC put out their guidance about the length of quarantine, they basically provided for options. So what they said, and this came out in early December, was that 14 days is still the best, but based on data that they have been able to gain, as well as some modeling, so basically using data from other things to adapt to use for this purpose, they were able to determine that a 10-day quarantine without a test or a 7-day quarantine with a test were also acceptable alternatives. So in that vein, we in Connecticut updated our quarantine guidance to say that there are 3 options for quarantine. So to be clear, the 14 days is still the best option because the virus hasn't changed, in the sense that it can still take up to 14 days for someone to demonstrate that they were infected after being exposed. So that hasn't changed. That's a characteristic of SARS, of the coronavirus in general, and that period is not going to change. So that is why 14 days is always going to be the best. It's really, if you look very carefully at the CDC guidance, it's really about the kind of, balancing the potential risk of a shortened quarantine with the fact that we know people don't always observe the full quarantine period, and understanding that we've been doing this for a year, and that longer quarantine periods can have other potentially bad side effects when you have to do it multiple times. So that was really the impetus for trying to come up with a scientifically based shorter quarantine period. So we in Connecticut have said all 3 options are possible, but it is the local health department that has the authority to determine what is the most appropriate quarantine period. So all of that to say is that if you are interested or want to know if a shorter quarantine period is possible for your facility, I would speak with your local health department.
Great, thank you so much. For the second scenario that you and Lexi discussed, was the staff or attendee exposure defined as having been within 6 feet for a total of 16 minutes? Or both classes completely closed?
For that situation, both classes were completely closed. This particular facility had closed classrooms, total classrooms, and did not try to distinguish exactly. It's too hard to distinguish who was within 6 feet for 15 plus minutes. From the case. And then once they started to get more, they had reports of other people becoming symptomatic. So they just closed both rooms right off the bat when they had first heard of the positive test.
So that's really helpful. I have another question about sort of the teachers in these situations, and this might be difficult to know based on the timing of when you collected the data, but is there any knowledge about whether the teachers in the outbreak situations were vaccinated? And do you believe the outcomes could have been different if the teachers had been vaccinated?
So I think we're really in the very beginning stages of having people vaccinated. So I think in all of these situations, most of the people were not fully vaccinated, and fully vaccinated means at least 14 days since the last dose of whatever vaccine series they're taking. So I think you make a good point. Certainly the goal of vaccinating everybody is so that hopefully we see less and less of these situations. I think what's challenging for childcare settings and schools is that for the foreseeable future, we will still have the attendees not able to be vaccinated. And so that is why the mitigation measures are still going to have to be in place for these settings until we have a vaccine for everybody.
Okay. In the situations that you described, were the children who contracted COVID under age 3?
So we're not going to share all the ages here.
I wasn't sure if you'd be able to.
Yeah. So I mean, again, the goal here is I will say that all 3 of these scenarios involve children of all ages. They weren't all just one age group. And so I don't want, so yes, there were certainly situations where these children might have been too young to wear a mask, for example. But all of these situations involve children of, I would say the usual age spectrum in a childcare setting.
Okay, thank you. So if you could provide some guidance or some insight into which symptoms staff should pay attention to when deciding whether to work or not in relation to the discussion about coming to work sick. For instance, allergic symptoms compared with possible COVID-19 symptoms.
Yeah, that is really, really hard. And especially now in allergy season. So I think what I am hearing a lot is certainly somebody that has a known history of allergies, right? That's a little bit situation than someone just saying, oh, I'm sneezing, it's the spring, I must have allergies, and they've never had allergies before. I think at the beginning of it, it is probably worth talking to your healthcare provider and determining whether a test is necessary, especially if they are not the usual symptoms, they don't get better with the usual treatment that somebody might have. I think we all need to have a very low threshold to be, you know what, I'm not sure, so I'm going to talk to my healthcare provider and maybe get a test. And this is, especially true if people have not been vaccinated. And I know that that's tricky, but I think certainly there are situations where, again, somebody at the very beginning is like, oh, this must be my usual thing. And then by the, a week in, they're thinking, well, usually by now I'm better, or these medicines would have worked and they're not working. And so what we're trying to do is prevent that week-long period where people are potentially being exposed. And so there's not a one answer, but it's just that people really have to be very in tune with themselves and their symptoms, and whatever symptoms they have, and recognize that for many people, especially for kids, especially for a lot of the staff that are working in childcare settings, their symptoms can be very mild. But that's still an opportunity for people. Even if you have mild symptoms, that doesn't mean that you don't have enough virus to transmit to somebody else.
That's really helpful. We have a few questions about travel and field trips. But before we get to those, there's just one more question about the physical space. So there's been this question says, we've heard that there's 3 feet of distancing versus 6 feet of distancing, and this is a recent change to some of the CDC guidance for K through 12 schooling.
Yeah.
Could you comment on just clarify the difference here and when it might be applicable in a childcare setting?
Yeah, so I think that the latest CDC guidance is for shortening the distance to 3 feet, specifically in K through 12 settings. And I think that is based on multiple different studies that have shown specifically in those settings, the likelihood of transmission occurring and people being exposed and getting sick specifically from an exposure in that setting is pretty low. And that has generally been our experience in Connecticut too. So though that recommendation is really based on data from those types of settings, I don't think that we can adapt that to childcare settings, understanding that, as we've discussed, you cannot implement all of the mitigation measures all of the time across the facility, because that's just the nature of childcare childcare, right? And so I don't think that we can really do that until we have the data that we're able to do that. And I would expect that right now that's really not going to be an option. And whether it could be done in like a school setting that's also in a childcare facility, I guess we'd have to discuss that. But in general, again, that recommendation was based on studies specifically in K through 12 settings and not in childcare settings.
All right, so it would be helpful if you could comment on travel guidance and how programs can apply travel guidance for vaccinated and non-vaccinated individuals. And this particular questioner is saying they're hearing about, and everyone's really hearing about, families traveling to see grandparents or staff and family taking spring vacations and then returning to childcare. Is testing recommended for the returning child? And I would add, or the returning staff.
Sure. So CDC did update, this has been a moving target, and they updated their guidance on travel on last Friday, so less than a week ago. And so they have now determined that persons that are fully vaccinated, again, at least 14 days or more since the last dose of their vaccine series, whatever it was, that are asymptomatic can safely travel domestically, meaning they do not have to test before or after travel or quarantine after travel, as long as they're well. They should continue to wear a mask and distance from crowds and wash hands. In regards to international travel, persons that are fully vaccinated do not have to test before travel or quarantine after travel, but if someone is traveling internationally, to get back into the United States, you must have a negative test in the 72 hours before you get on the airplane. So that is it regardless of if you're vaccinated or not. If you are not fully vaccinated, which certainly includes any child in a childcare setting, the recommendation is actually to test, and this is the same for international or domestic travel, is to test 1 to 3 days before the travel, again 3 to 5 days after the travel, and quarantine for at least 7 days after the travel. If a test is not done after travel, then the recommended quarantine period is 10 days. So this is tricky because these are recommendations. As everything from CDC is. We previously in Connecticut had a travel advisory that was backed by an executive order, and that expired in March. So currently our travel guidance is exactly that. It is a recommendation and defers to exactly what the CDC guidance is. So good thing there, and that it looks exactly the same as CDC. It does not have the executive order in regards to enforcement. However, I think it is really important to share with your staff and attendees what these recommendations are and the importance of complying with them. And then I will leave it to Commissioner Bai or others about if there are additional measures that childcare settings could take in regards to this issue.
Okay, great. Thank you. So we do, one of the questions we have is about sort of the changing guidance, and I think this must be a challenging place for providers to be in. The guidance is changing, and sometimes the CDC guidance gets less strict. So should programs remain with more strict guidance, or should they change their policies as guidance changes? And this is like broadly writ about the whole set of prohibitions and restrictions and also protections. And that's a question I think for you, Dr. Sosa, but also for you, Commissioner Bai, because I think that it's a challenge being in this climate to know that you're trying to really follow all the rules and keep people safe. So I don't know who would like to answer first.
Well, I'm happy to answer, which is an answer that's so hard because as you can hear with Dr. Sosa, we have guidance for you that we ask that you follow, but there's still judgment, and you're still dealing with people and families who, maybe aren't being as considerate as they could be when it comes to bringing the virus into your program. Or I know some of the stories I've heard from directors are, families had birthday parties and then that came back into the center, and that led to a large outbreak and a shutdown that inconvenienced everyone. So we try to keep the guidance as clear as it can be, but it's not perfect. And, I was just on with camps who say, well, this is different for camps than it is for schools, and why do you have these stricter rules for the buses? We're trying to stay aligned and give clear guidance, but this virus is complicated, and so is the whole reopening complicated, and you all know that. You've been dealing with staff who are worried and families who are worried and doing your best. So, you know, if there are particular areas of guidance where you think we could do a better job supporting you with families, you know, we're happy to do that, but, you know, you let us know. I'm not sure that I answered the question fully, and Rachel, you can get me straight if I haven't.
No, I think it's a really difficult question, and I think that it will. It's a complicated one, so I don't think there's a straight answer. And you know, Dr. Sosa, you're nodding your head. I think that that this is a difficult one, and people are really just trying to do the best by children and families. And it's really hard when, as soon as you get things under control, you know, the policy changes and people just adapted to one set of restrictions or another. So we do have one question before I move on to ask Commissioner Bai a question about staffing. But Dr. Sosa, I wonder if you could just give us some insight about how folks should be thinking about cohorting if they're planning on taking field trips or taking children off site.
Yeah, that's tricky. I think the idea is trying to maintain the cohort through, you know, as much as you can throughout whatever event it is. And I can imagine that could be tricky on a school bus. And not that I'm particularly concerned about spread on a school bus per se, but if you have a lot of kids on a school bus, and I know how kids can act on a school bus, that could be tricky. So, I mean, I think these are the things to think about when someone is thinking about trying to embark on field trips and other types of things. I've certainly gotten that question from others for schools, for example, thinking about, okay, well, if we wanted to have a field trip, how would we go about it and how do we do it? And I think that if there is a place that wants to consider that, it will take a lot of advanced planning, with cohorting not just being one of the many things to consider when you're going to kind of go outside of your controlled setting to a setting that is not as controlled.
I really appreciate that. We seem to have lost the commissioner momentarily. So what I'm going to do is actually, I want to share some guidance.
I'm here.
Oh, fantastic. Fantastic.
Yeah, I've been here. I just turned my camera off, so thank you, Dr. Sosa and not me.
So I have a question for you about staffing and cohorting. So the question is, the need to cohort has implications for staffing and especially for cost, because it requires hiring and scheduling more staff than generally needed. Is there any financial assistance available from the state to cover some of these expenses?
Yes, there is. We are sending grants out to programs to help with some of these costs through our ARPA funds, the CRRSA and the ARPA funds, to help programs with those costs. We know you have reduced tuition, increased costs, increased needs for staffing, and those grants are coming out in the very near future. We're waiting for the federal funds to arrive, and then we will get them out to programs. The CRRSA funds have arrived, but the grants are in the American Rescue Plan dollars. And we met just this week with Congresswoman DeLauro, and she is getting us information about when we can expect those funds, but we know you need them now. And so we're getting set up so that when they get here, we can get them out as quickly as possible.
Great. Thank you. And this is a question for both Dr. Sosa and Commissioner Bai. Programs have been asked to limit the number of visitors. What are your thoughts on allowing visitors into programs, including parents?
So again, I think it's a matter of why the person needs to be there and your ability to continue the mitigation measures when you add additional people to the individual room or setting. So, you know, if you're going to add more people, you need to still make sure you can social distance as much as possible and mask wearing and all of those things. So it's really a matter of, you know, what the goal is and whether you can continue doing that.
And Dr. Sosa, do you know if there's any implications of the new variants for any of the precautionary measures that are in place?
So the variants, and I will say that in the same weekly report where the childcare data are, also we have variant surveillance in there as well. So you can see what the current numbers are, which are, I know it's hard for, the average person to interpret. I will say that there are two variants that are, make up the vast majority of what we're seeing in Connecticut right now. So the B117 variant, which is the one that was originally detected in the United Kingdom, which is a highly transmissible variant. And to be clear, there are many strains of SARS-CoV-2, just like with other viruses. But this one's important because it has demonstrated to be much more easily transmitted, which means that the mitigation measures are so important in making sure that we are adhering to them 100% of the time. They work against these variants, but any slip or change in the mitigation measures, these variants we don't have any flexibility. It's going to be more likely to spread. So that's really the hard part, and that's why it's so important that we continue to do that as much as possible, and that we get as many people vaccinated as possible.
Great. Dr. Sosa, one or two more questions. Is the risk of transmission through containers or other things from grocery stores or restaurants, is that still a concern, or are we in a point where the precautionary measures keep children safe?
Yeah, I'm certainly not worried about my grocery store containers or restaurant containers or things like that. I think that's one place where we've seen a big change, right? Thinking about where we were a year ago and worried about how, like, things that we're touching. I think we've gotten very comfortable with that, the fact that SARS-CoV-2, while a brand new virus and has thrown us a lot of curveballs, it is still like other coronaviruses in the sense that it is primarily spread by respiratory droplets and people breathing and coughing and getting these droplets into the air, and then other people nearby breathing them in. So again, while touching things is not the primary mode, it certainly could be. But that's where the basic cleaning and disinfection that people are doing should be sufficient to address that particular scenario.
And finally, we have a couple of questions about staff being vaccinated. So if all the staff are vaccinated, can they be without masks when children are not in the building? What are some recommendations there if everyone is vaccinated?
Good question. So the guidance from CDC, and I will say that this is going to continue to evolve over time as we get more data and more experience and more people are vaccinated. But right now, while CDC does say that if you are fully vaccinated, you can congregate with other fully vaccinated people in a private setting, that does not extend to workplaces or other places like that. So we would recommend that if you are with everybody that you work with is vaccinated and you're at work, you need to still be wearing a mask. This includes my workplace, your workplace, everybody. Like, we still want everybody to be wearing masks when they're out in public, which includes a workplace setting.
And do those fully vaccinated individuals or staff members need to test for COVID if exposed and symptomatic? Okay,
so if a fully vaccinated person is exposed but is not sick, they do not have to be tested and they do not have to quarantine. If they are sick, they need to be evaluated, and that is likely to include a COVID test.
Great, that's really helpful. Commissioner Bai, I just have one question remaining before I show some of our most recent guidance. So the question is about camps and group sizes, and does the group size requirement apply outdoors as well as indoors? If there's anything else you wanted to say about youth camps for those who happen to be listening.
Yes, right now the group size is 20 for camps, indoors or outdoors. Those are the cohorts that the Reopen Committee landed on. But again, in May, the executive order expires May 20th. These are all subject to the executive order, so that could expire, but at this point it is 20 and camps should plan on 20.
Great, thank you. All right, so I thank everyone for all of your very thoughtful questions. We always put together a Q&A after after webinars like these. And right now, what we wanted to share with you is new guidance or revised guidance that's posted on our website. And we'll share a link to where this guidance can be found in that Q&A window for everyone. So this is just the most recent guidance about how to keep up with health and safety precautions. We're doing our best to communicate as actively as we can about changes in guidance, any memos that we needed to update from when they were originally sent, or if things have changed. So please continue to check our website for updated memos and guidance. And many of these memos and guidance address many of the questions that have been asked today. So we thank you very much for joining us. We will post a link to this recording on our YouTube channel, which is also linked on our webpage. As I mentioned at the beginning of the broadcast, we'll also have a Spanish interpreted version of this presentation available early next week. And Commissioner Bai, I don't know if you want to close.
Sure. Thanks, Rachel, and thanks everyone for your participation today. Thanks to DPH. We all have the same goal to try to keep our kiddos and their families, and especially our teams, safe and healthy. So thanks for all you're doing, and thanks for joining today. Have a great afternoon.
Thanks, Commissioner Bai.